Well, I am glad to see you all here. We're going to talk about sex. Are you ready?
You bet.
You bet. Okay. A little scared, a little anxious. Work a lot with patients in a lot of places on a lot of issues. Stuart Drescher, I don't know if you had a chance to see him this morning, was talk about the work that we do with this phase model in general, helping people cope with and work with a whole variety of chronic illnesses, including CFS, FM. It's been translated into lots of languages. We're using it around the world. We're getting a lot of interesting results. One of the things I've noted in the past several months, maybe in the past 16, 17 months, is that my patients are coming in and this is a topic they want to talk about for lots of interesting reasons. But let me just move into the slides here. So what is the most important personal concern patients with chronic illness are least likely to talk to their physicians about? Well, sex. Now, and interestingly, in studies, this is a big issue in quality of life. So, let's begin. Why do increasing numbers of people, why are they coming in and wanting to talk about it? Well, there's lots of interesting reasons for that, but here are some of the ones that have caught my attention or that I'm focusing on. We are the first generation of humanity to ever live this long. The first. In Albany, New York, which is about 2 hours. Anybody here from New York besides me? Yes, ma'am. Where are you from? Oh, my God. You're my neighbor. All right. Okay. Well, the average lifespan in Albany, New York in 1923 was 52 years. And now, depending on gender and race, et cetera, it's somewhere between 77 years and 82 years. That's public health. That's antibiotics, that's technology, that's modernity. That's not evolution. So we have not had time to catch up. So we are the first generation of people to be sexual, ongoingly, if you will, in our 40s, 50s, 60s, 70s, 80s, 90s. I guess we'll see. I guess we'll see. Plus, an awful lot of people who would not be alive at, say, 30 or 35, are now. So how we're sexual, how we adapt, how we cope is very much influenced by the technologies that have kept us alive and how long we are now alive. And there's no rule book. There's no libretto. We are writing the rules now. So what does it mean? When my grandmother was my age, and she helped to raise me, she was 3 years away from death. Now, I like to think I'm not 3 years away from death. But brand new rules. Now, here's an interesting thought. According to JAMA, in the mid-90s, the Journal of the American Medical Association, half the U.S. population had a chronic illness then. Half. And they weren't talking about mental illness. They weren't including in that depression and all those kinds of interesting things. And it's not going to be one chronic illness per customer. So as we age, the opportunities, I mean, I already have osteoporosis. I got diagnosed with lupus when I was a kid. And I'm sure without a whole lot of effort, I can accumulate many, many more diagnoses. It's not something I'm really wanting to do, but I'm sure it'll happen. Now here's where it gets really interesting. Have you noticed that the media is kind of interested in sex? Have you noticed that? And I don't know, I think that might have something to do with why there's an increasing number of people coming into my office and wanting to talk about it. Now, it's a very interesting time that we live in, because on the one hand, there are Victoria's Secrets ads on TV, which 15, 20 years ago would have been soft pornography. And I don't think Vicki has any more secrets. I think they're kind of right there. In the same token, we live in a culture that says we can't advertise condoms on TV. So we have a very interesting mixed culture about what's sexually appropriate, what's not sexually appropriate. And in this cultural focus, there's a great divide. There's a lot of people that feel that sexuality However they want to express it is fine, and there's a lot of other folks that have a lot of thoughts and feelings about when sex is appropriate, under what circumstances, and there's a big continuum. There's a big division there. And that's the culture that we live in. So I think you can boil that down to, it's confusing. It's confusing. What's good, what's bad, what's appropriate, what's not appropriate. So if you take all of that and add it to what's good and what's bad and what's appropriate and what's not appropriate when you're sick, when you're disabled, when you're chronically ill. There's a lot of bias in the culture that says if you're disabled, you're not supposed to have sex. Disabled people don't have sex. Did you know that? Oh, I bet some of you do. So we live in a very interesting time in terms of our country, what it means to be sexual. In the Clinton years, in the Victoria's Secret years. Europeans think we're nuts. They think we're absolutely nuts. Nonetheless, this is where we live. So we have to figure out how to be sexual or not. You don't have to be if you don't want to be. It's not mandatory. In this culture, from the context of also coping with a chronic illness. And probably more than one, if you're like at least half the US population. And it's not going to be that there's going to be one chronically ill person in your family. It's going to be several. It was an interesting article in this past, I think it was the past Tuesday's Science Times, of a woman who was now 80-something, her spouse was 90-something, and they're talking about their emotional and sexual life. And she's talking about how her children, who are in their 50s and 60s, and their children who are in their 30s and 40s, and their children who are teenagers or younger, and how they're all coping with and thinking about and relating to these folks who are alive this long, and could be alive for I don't know how many more years. And how do they function in their relationships, in their sexuality. So there's a lot for us to think about there. Now, here's just to sort of reiterate, it's part of what we were talking about, that we live with these cultural contradictions, these mixed messages about sexuality. Should you? Shouldn't you? What's wrong? What's right? What's moral? What's immoral? It's a culture war. What's sexually conservative? What's sexual freedom? Again, what's wrong? What's right? And how does that impact your feeling and your thinking on these issues? We have a lot of sexual taboos, and we have $1 billion sex industry. Actually multiple billions of dollars. Which says to me that a lot of people who may think they shouldn't have sex or be sexual, or that they might publicly say that they're not or they shouldn't, they actually are. They're consuming pornography and a whole variety of products that are part of that industry. Which, again, it's up to you whether that's wrong or right, but this all influences our thinking and our feelings about ourselves as sexual beings. This results, again, in sexual complexity in the face of your chronic experience. So, here's what my patients don't say about sex. You ready? They don't say, I'm having too much sex. Pat, can you help me? Can you do something about that? That's what they don't say. Now, here's what they do say. I don't have sex anymore. I don't have enough sex anymore. I don't know how to have sex anymore. And can you help us? Or can you help me? And those are very, very, very difficult questions for patients to bring up. But if they don't, I see relationships fall apart. And I see lives fall apart. It's very important. Just speaking in the context of a couple's relationship. However you define.
Question.
Yes? Why what?
Why does it hold a relationship together?
Why does sex hold a relationship together? Well, it's a very good question. It's a very interesting question. Do you think it does?
In some ways.
Sex can be, again, and this is very personal, and people can hold forth on it in a lot of different perspectives, be it from a spiritual perspective or a physical perspective. Well, I'll frame it this way. It's a very powerful force in life. And it's such a powerful force like eating and breathing and being social and living in the world. And when I say being sexual or sex, that our sexuality not just encompasses the act of sex or literal acts of sex, but we are sexual beings as we move through the world. As we move through the world. It doesn't necessarily have to mean that you're engaging in particular sexual acts. Yeah, that how we dress, how we think, how we behave, there's a sexuality that's inherent in that, or can be inherent in that. And that whether we're aware of it or not aware of it, certainly impacts how we interact with the world. Gender impacts the workplace, any social gathering, how we see ourselves as children, as adults. So in the context of a relationship, if we don't address the issues of sexuality, however they've been or not been, and we're going to get into that, can be a very destructive thing if it's not consciously brought out and dealt with. And certainly culturally, we are encouraged to not talk about it, by and large. By and large. At least not talk about it in a, how do we help, how do we deal with it. You know, we might encounter the sexuality in titillating ways, either in film or things like that, but that doesn't address how it's affecting your life. Anyway, to get started with a piece of this, why couples may be having less sex. And we're going to talk about it in three different aspects. We're going to talk about it in a physical aspect, a psychological aspect, and a social interactive aspect. And just reflecting on the good question that this woman just asked, this isn't an exhaustive list. Sex is a very, very, very broad thing with many, many, many dimensions. And these are the ones we're just focusing on today to get us thinking and talking and reflecting. This isn't the be-all and end-all. So here are some things to consider from the physical aspect. Here's some of the reasons why couples may be having less sex physically. Because they're in pain. Because they're in pain. They're in fatigue. They're in fatigue states, various fatigue states. For women, there may be vaginal pain, dryness, physical changes on the physical level. For men, erectile dysfunction. For CFS and FM patients particularly, but other certainly chronic conditions as well, is the exertion rebound, delayed symptoms. When you think about having sex, it's sort of like thinking about, do you walk to the mailbox? Can I exercise? It can be an aerobic experience. It's a physical activity, and you have to think about it in those ways. And of course, diminished libido. You can want to have a whole lot less sex when you don't feel well. Can you relate to that? Does that make sense? Yes? I hear giggles. I hear giggles. Here are some of the psychological aspects why people have less sex, couples may be having less sex. A fear of inflicting harm. Many times a spouse will come in to me and say, I don't want to hurt her. I'm afraid I'm going to hurt her. Anybody relate to that? That sense of, I see nods, I see some nodding. I don't want to put pressure on him. I don't want to inflict physical harm. I don't want to inflict psychological harm with expectations. Body image. When we've been ill and our bodies change, and sometimes they do or sometimes they don't, but when you've been ill, you certainly feel like your body's changed. Or maybe you've had surgery, you have scars. You can be fearful about being naked or partially naked with somebody, let alone yourself. A lot of folks, a lot of us, we don't want to look in the mirror for fear of what we're going to see. Does that make sense? Do you relate to that? I see nodding. Performance anxiety. Do I remember how to do this? Oh my God. Can I do that? Can I? Well, I'll save you the visual, but you know, it's that performance anxiety thing. Grief. We grieve about loss of function. We grieve about losing our jobs. We grieve about losing our roles as a mom, as a friend, depending on how our disabilities limit us. We also grieve that loss of function about being a physical or sexual being. That's real. That hurts. And about the loss of function. You can be guilty about it. And I don't know about you, but people can be a little bit angry about this. And who do you talk to that about? Who do you talk to about that? The places are limited. People without chronic conditions have trouble talking about that, especially as we age. Now, thank God for Bob Dole. All right? I didn't vote for the man, but I like the man. Okay? And I think he's done a lot to help men talk about these issues, and women too. One of the things that happens psychologically when folks are ill is, one way we can clinically talk about it, but I'll spare you that, except to say, we might talk about it as a regressed ego state. I'll put it differently. Any mammal, a person or a pooch, when we're ill, when we don't feel well, we put our tail between our legs, we whine. How many people whine? I'm working on learning how to whine. I was brought up, anybody here else besides me Irish Catholic? Gee, not a lot of Irish Catholics here. Oh, okay. Okay. Well, in an Irish Catholic Eastern perspective, you make jokes and you walk it off. You don't whine.
Yeah.
But you need to express these feelings. And when you're sick and you feel pulled in and your tail is between your legs and you're sad, you feel diminished. You feel smaller. You feel younger. In that smaller, diminished, natural, normal state, in the experience of illness or disability, you don't want to have sex, as a general rule, because you have to feel older, more in charge of your body, more comfortable, etc. That's a very common psychological aspect of why people don't want to be sexual. Psychosocially, you and your partner, you and your spouse, why they're having less sex. Well, when all these changes occur, and we're going to talk about the phases of illness in a second, but when all these changes occur, people get angry, they get resentful, they feel guilty, they feel loss. Not the best environment for romance, if you will, right? And the role and the relationship dynamics change because of that regressed ego state. If you're in a relationship and your spouse gets ill, the power dynamics change. The power dynamics change. And when you're in the role of a caretaker, it's hard to think of the person you're taking care of as somebody you also want to be sexual with. Can anybody relate to that? Does that make sense? And when you're the person being taken care of, it's sometimes difficult to think of your caretaker as a sex partner. It can feel parental. And even if it doesn't feel parental, it's a shift in the dynamics of the relationship. And that makes a parity in sexuality more difficult, more complicated. So the dynamics change. Not to mention the outer world dynamics that change. Maybe you are taking on the role of not only breadwinner, but housekeeper, because your spouse can't do all of that. And now with all these role changes, or vice versa, maybe you were the housekeeper and also working, but now your spouse, husband, can't work and you're working even more. When all these roles change, it impacts your social life, your sleep life, and your sex life between you and the person who you shared these roles with. It's a big change in the family system. It's a big change in the couple system. So you have those issues of being vulnerable in the power balance. It's tough to feel sexual when you feel vulnerable. Anybody relate to that? I see nodding. Anything you want to say about that? Not a chance. Okay, I'm going to make you talk, Now's your chance. It's difficult to figure out how to be the sexual initiator versus the caretaker. If you are the sexual initiator, if you talk to most couples and you do sex therapy with couples or family therapy with couples, there's typically one person who's the primary initiator. Not always, but usually. Well, if you were the primary initiator and now you're the caretaker, that gets real confusing. Gets real confusing. And that's often when the spouse might say, I don't know how to put that back together, and I don't want to be harmful, and I don't want to be intrusive, and I don't know what to do, etc., etc. Or I used to be the initiator, and now I'm the caretaker, and I'm sick of it. And when do I get my wife back? I didn't sign up for this. And that's not being callous. That's real. This is a loss for everybody. It's a big deal. How do you put together being a sex partner and a patient? How do you be a patient and feel sexy? You figured that one out? That's tough. It can be done. It can be done. So here are those questions again. I don't have sex anymore. I don't have enough sex anymore. We don't know how to have sex anymore without causing pain, without getting too tired, without having reverberations 24 hours, 48 hours later because then you're too tired to walk to the mailbox. So here are some of the clinical questions, but they're good questions regardless whether they're in a clinical context or not, that we might start to ask the couple. What are the expectations of each partner? Sexually, in general terms. What did your sex life used to be like? How has it changed? But what would you generally expect? How much sex does each partner want? And typically, in the best of circumstances, it's not the same amount. One person will say, oh my God, he wants to have sex all the time. It's every 2 weeks. Laugh. Gotcha. And then someone will say, he never wants to have sex. We only have sex once a day. I've heard that. I'm not making that up. I'm sitting there going, oh my God. I'm just trying to figure the logistics of this. So under the best of circumstances, that's an issue. So when you introduce someone into the system, into the couple who's ill, the disparity gets greater. It gets greater, typically. And you'd be surprised. Sometimes you will find that's the patient who wants to have sex again and the partner doesn't. The well partner doesn't. Wants to have sex a whole lot less. I see talking, giggling on that one. Who was the primary sexual initiator? And how have those role changes and dynamics impacted that person? Those are questions we want to begin to explore. And how do you particularly feel, in reflection on the expectations, how has the sexual relationship changed? Some of the basic assessment questions. Basic assessment questions.
Can I ask a question?
Yes, ma'am.
There's one issue that's not there.
What is that?
And it bothers me.
The woman's saying there's one issue that's not there. One question. What is that?
The problem is when you become ill, many of us have lost the drive.
Libido. The loss of libido. The loss of sexual drive.
Not able to carry it to climax. That doesn't mean we don't know how. It means it's gone and we don't know how to get it back.
Right. We're going to talk about
Our
that.
husbands are fine.
Right.
It's not them. It's us, the sick ones.
Right. Right. Yes. Absolutely. One of the issues is when, I'm going to use the royal we here for ease of conversation, when we get sick, you lose your interest. You can, not everybody, but you can lose your interest almost completely.
I didn't lose interest, I lost the ability.
So, okay, separate issue. Someone can have the interest, but they lose the ability to climax. And that becomes a frustrating experience. It becomes a frustrating experience for both partners. We're going to talk about that. Okay. Not that I pretend to have all the answers, but at least we're going to talk about it. Solutions and strategies. Again, not an exhaustive list, but a place to start. A place to start. So beginning with the physical aspect. Diminished libido. In response to pain and fatigue and vaginal pain and diminished libido, exertion, rebound, delayed symptoms. This is one of the places that, when you're talking in general terms about a pain control protocol, we're talking about controlling your pain. When Cindy's talking about controlling pain, we need to think about controlling pain sexually. How does it feel to have sex? So not just that your knees hurt, but that vaginally you can be in pain too. This is part of what has to be talked about. Or for men, for that matter. We need to do a medication evaluation. Frequently people lose libido because of the combinations of medications that they're on. And that's something to talk about with your physician and look at the combinations of drugs that you're on. Because that's often it's not the only culprit, but it's often a culprit. One of the things I'll be talking about in a second, it also can have a lot to do with phase of illness you're in. When patients are in a crisis phase of illness, or even in phase 2 of illness, they're not that interested in sex. And we're still trying to conceptualize ourselves as the sexual creatures that we were before we got ill. And so that's also part of the refiguring. But staying on the physical aspect for a second, let's do a medication evaluation. Talk to your physician about that. Also, in that process, it's to consider sexual response medication. This isn't for everybody. You need to discuss it with your physician, folks like Cindy, but for men, thank God for Bob Dole. And they're producing a variety of medications now for women to help them with sexual response. Maybe you hadn't heard about that. Well, yes, ma'am, they are. Well, Cindy, do you want to weigh in on this one for a second, or you want me to continue with this? Oh, I'm keeping going. I'm what you call on my own with this for the moment. No, I'll do it. There are a variety of medications that are being, people are using some of the medications that are used with men. I want to name specific medications, but they're utilizing them with women and they're having some good responses. So that's worth talking about. Just right there, that's worth talking about. And there's more in the pipeline that'll be out very soon. But some of the same ones that are being used with men are also being used with women to increase sexual response. Okay? One of the things that helps with the physical aspect is scheduling and reprioritizing. We have to begin to think about pacing and using different kinds of interventions to help us with our scheduling and reprioritizing. So from that perspective, for example, and I'll talk about this more later, if you have a choice about, I'm going to do some physical exertion and some physical exercise, I'm going to try to get that back into my schedule, I'm going to really use pacing techniques. Anybody folks who talked about pacing techniques? Well, sex is something that you've got to think about in terms of your pacing. And if you're going to have, say, date night, as one of my patients talks about it, she will help reprioritize some of her activities so that she can have a date night. Once a week, once every 2 weeks, whatever it is. And then anticipates that if she has date night, she's going to be really tired the next day and or the day after. So if she has a choice, for the sake of herself and or her partner, between going to the Piggly Wiggly or having date night, she's personally at this point opting for date night. Now, you don't have to. You may want to go to the Piggly Wiggly. But we need to think about this. We tend to think about sexuality as something that just sort of happens. It just sort of occurs. No. We have to think about it consciously. Once we get out of the dating phase, whether we're chronically ill or not chronically ill, and the plane lands, you know what I'm talking about? That sort of, once we look at that first 6, and there's interesting studies about this, 6, 12, 18 months of the honeymoon phase, when sex is a priority, contact is a priority, a whole variety of things are a priority naturally. Well, at some point, I call it the plane lands, and you get back to real life. And that free introductory offer period is over, you know? You know what I mean? Not that I have any experience with that. Right? Well, you still schedule going to the store, and you still schedule when you might see friends. And sex has to become a conscious thought and effort. I mean, oh, that's not romantic. Well, not having sex at all is a whole lot less romantic, if you ask me. So just food for thought. We'll come back to some of these things if time permits. Psychological aspect. The fear of inflicting harm, the body image, performance anxiety, all the things that we talked about. With our patients, we do trauma support. Now, I don't know if anybody else has talked about this today, but you may have noticed, some of you, that this whole chronic illness thing is traumatizing. I don't care what happened to you before. I mean, I do care what happened to you before. But you may or may not be a sex abuse survivor, and you may or may not be a domestic violence victim, and you may or may not have cancer before, or any number of things that can happen to people. If none of those things have happened, the illness that you're experiencing can be traumatizing in and of itself. In and of itself. When you lose your ability to walk around freely, when you lose your ability to walk, when you lose your ability to think, to whatever degree, I don't know about you, but that's kind of traumatizing for folks. And that often and appropriately requires support and help. Well, on this front too, people really feel like they have physically and emotionally changed. And it really impacts their sense of self and femininity and masculinity, and thus their sexuality, which is a core part of who we are. I mean, when we look at each other, one of the first things that we think is gender. What sex are you? What race are you? Etc. It's core to who we are, and it impacts us on that level. So we work around those issues. We work around self-esteem measures. We do grief work. It's funny to think about doing grief work around sexuality, but that can be necessary. We teach people how to pace. We teach them, we give them a phase education, meaning we teach them the 4 phases and about the phases of illness and how you feel physically and psychologically about yourself in phase 1 is going to look different in phase 2 and 3 and 4. We're going to get to some of that. We talk about role reorientation so that couples can cope with these changes. And thus the psychosocial aspect in response to the anger that we can appropriately feel. And let me say this for permission, for the currently well spouses. You have every right to be angry about the changes in your sexual relationship. You have every right to be angry about the changes in the relationship, period. That's appropriate. Nobody teaches us about this in school. Everybody's going to get chronically ill, pretty much. I mean, you might die in a car accident or a plane crash, but everybody's going to get chronically ill. And everybody's going to die. Nobody gets out alive. Okay? That's how it works. So, that being the case, these issues are definitely going to come up. Well, nobody taught us about that in school. There was no primer. There was no textbook to help us with these concerns. That education just wasn't there. That's why we're here. So in addition to the pieces I've already mentioned, teaching about new role reorientation in the couple, looking at scheduling, looking at date night, that we understand that sexual adaptation, or adaptation, however you like to pronounce it or spell it, is an appropriate thing to do. And part of what we have to understand is that regardless of whether you're chronically ill or not, that all of us, as we age, have to adapt sexually. We are not the sexual creatures we were at 12, at 15, at 21, thank God. And then, you may or may not have had children as a man or woman and how that affects you. At 30, perimenopausal, etc. You change. Your bodies change. They're supposed to change. That doesn't mean you stop being sexual. Everybody has to do that, whether they're chronically ill or not. So whether you're big or small or skinny or you're in or not, it's natural. Well, I'm going to talk to you very quickly about sex and the 4 phases of illness. Any of you get a chance to see Dr. Drescher's presentation this morning? He talked about my work, the phase work, a little bit there. Okay, well, we'll talk about it more if we have a chance. But there are 4 phases of illness, and we've got really good research to support this. And the first one is the crisis phase, the second one is the stabilization phase, the third is the resolution, and the fourth is the integration phase. We got good research to support these phases exist, and that you guys go through them. And if we understand your sexual needs and experiences as being understood separately as part of a particular phase of the illness, it's going to really help how you think about yourselves as physical and sexual creatures. And in fact, it's going to help you, period, in terms of how you think about yourself as a human being if you look through the phases. Important to consider that partners are also impacted by the phase experience. So in phase 1, just to quickly go through this, these are some of the, we look at phase 1, this is the crisis phase, and there are 3 domains in each phase: the physical, the psychological, and the social. In phase 1, this is boiled down from 150 hours of curriculum, so bear with me. I'm going to try to scream through this in 10 minutes, but on the physical behavioral level, you can go through a coping stage in phase 1 for quite some time before anybody figures out how you're sick. It takes the average person with an autoimmune disease in the United States 3 years to get diagnosed. And your onset may be sudden or it may be long. But physically, you're going through massive change. Psychologically, depending on the intensity of that onset, this is what people typically experience. Typically, a loss of psychological control, ego loss. Meaning, again, whether you're a puppy or a person, when you get really sick, your public self begins to intrude on your personal self. You find yourself, I can't find my way home. If I went up the stairs this morning, I can't do again this afternoon, or I find myself not able to distinguish the celery from the lettuce at the produce department because you can't think. Those kinds of physical changes result in psychological changes. When people get sick, they get ashamed. That's a natural response. It's not pathological. And depending on the intensity of it and the extreme nature of it, they can be self-hating. They can have despair. They can be in shock. They can be fearful of others. I don't want anybody to see me like this. What will they think? People hide. That's normal in the crisis phase. And that ego regression we talked about before, who wants to have sex when you feel like that? That's normal. Others can experience shock or disbelief. They can be vicariously traumatized by experiencing you in the trauma phase. Clinicians and physicians, psych people do all the time. It's hard to hear. It's hard to watch. You people are suffering profoundly. Depending on the maturation of the family that you're in or the organization that you work in, maybe you're already in a family that's getting a divorce or is having money problems. So when the illness hits, and truly hits, how tough the situation was before the illness hit is going to have a big impact on how bad the crisis phase is. We spent time, my organization, working with the firemen's families from 9/11. Okay? And there's a lot of illness, there's a lot of shock, there's a lot of trauma, needless to say. How badly they're experiencing it and how much recovery they're still going through has a whole lot to do with what their families were like before the buildings came down. Well, you've been through your own 9/11. You've been through your own traumatic experience to greater or lesser degrees. And that results in crisis phase, people sexually shut down. When you're in crisis, you don't want to have sex. And people by and large would expect that from you. So some of the things to keep in mind: sex in the trauma phase, very low libido. You're in survival functions. When you're in the crisis phase, you're trying to survive. How do I sleep? How do I eat? How do I cope?
That's very strange.
I think I'm being stressed. I'm not sure. And it makes you want to sexually shut down. Phase 2. In phase 2, you're not better. You're stabilizing. This is where you're carving order out of chaos. Order out of chaos. Physically, again, you're not better. Maybe you're plateauing. Maybe you're recognizing your symptom complex. Maybe you've gotten a diagnosis. Maybe you haven't yet. But oh, that's right. If I drive to the store or the mall and I don't make a detailed map as to where my car is, I'm never going to find it again. Okay? Or if I wash my hair on Tuesday and I put my hands over my head with my nearly mediated hypotension, I won't be able to wash my hair again until Friday because I'm exhausted. Okay? You're carving, you're beginning to understand your own symptom complex. Now, physically, you might have some budding interest in sex again. Maybe. But between the body image and is it going to hurt, etc., you're a little reluctant, to say the least. Okay? And that budding interest in physical fear wreaks havoc on couples. And it's normal. Psychologically, increased caution, secondary wounding. Here's what happens psychologically in phase 2. People seek out others of like kind. If you've been through the crisis phase, again, I don't care whether you're a fireman's family, if you're a kid who lives in South Central, or people in this room, you will seek out others of like kind who have been through what you've been through. Well, not all gangs are created equal. This gang might be in a slightly better shape than the gangs in South Central. And not all gangs give you good information or the proper support. But that's why we're here. You're trying to learn from each other and learn in this experience. This is a normal aspect of the stabilization phase. We seek out others of like kind. And we often go searching for those to help us. This is where, see, clinicians, we don't like this part. This is where the patient comes in and they're very impatient with us because we don't know what we're doing. Now, the truth is frequently we don't. Okay? And we can call it borderline behavior and doctor hopping and all that sort of thing, which it might be. I'm not saying you're not crazy. Okay? I'm not saying that. But it also might be very normal. Might be very normal for you because maybe your practitioner doesn't know exactly what you're going through. It's a very normal process to look for other sources of information and support. You're also going to run into the experience here of getting a little bit traumatized. See, we live in a culture that says if you work real hard and tell the truth, everything's going to be fine. Is that true? That's what the culture says. That's the implication. Well, you find out that if you share this information with some people, they're going to have a real problem with it. They're going to be very uncomfortable with it. And I mean, not necessarily about sex at all, about what your illness experience is like. Not everybody is comfortable with that experience. So psychologically, the role and relationship dynamics change a lot because you're pulling away from some of your old supports and you're checking out new supports. You can pull away from some of your old relationships and be checking out new relationships. And in your illness experience, again, there's boundary confusion. Am I a person with an illness or an illness with a person? I used to be somebody who could get up in the morning and make my own breakfast and make my breakfast for my children, etc. Now I can't do that anymore. Well, in that context, there's a lot of social interactive conflict. This is where the spouse will come in phase 2 and say, I didn't sign up for this. Acute experience illness, I understand. Better for worse, but as the joke goes, not chronic illness. Okay? And people try to be their pre-crisis self, but they can't be. Because the point is, if you're chronically ill, you can't go home again. You're not going to be that person again. That's the truth of it. You're going to become a new person. Well, often, if people try to be that old person, they get on a loop between phase 1 and phase 2 of crisis and stabilization, where they're trying to recapture that pre-crisis life. It becomes increasingly difficult to do. And they get more and more tired, and more frustrated, and less interested in sex. And what we like to call in the field, bed death. So budding interest versus physical fear, role relationship dynamics, role confusions, the caretaker versus partner, sex initiator versus partner, changes and limitations, residual concurrent feelings and attitudes. These are all the pieces we need to be thinking about and talking about with each other. Now, if we get the support we need, if we get the interventions that we need, we can get out of that phase 1, phase 2 loop and hopefully begin to move into a resolution phase. In that resolution phase, the individual begins to realize that, wait a minute, I'm beginning to accept that I'm going to go through periods of relapse and remission, and that's normal. That's not failure. For you to go through periods where you get sick again is what happens in chronic disease. Because if you didn't go through periods of getting sick again, or sicker again, then you'd either be dead or well. But by definition, this is what happens in chronic experience. People begin to develop the emotional muscles for that, the psychological ability to tolerate that kind of ambiguity. Now, what also happens here psychologically is at this point there's a grief reaction that's really different from phase 1. When you're in the crisis phase, you're scared, you're angry, you're going through all these changes, etc. Well, here, this is where the person realizes, boy, I really am different, and I can't go home again. This is really a whole other level of change. People typically need support, whether it's from their counselor or their rabbi or their minister, whoever it is, their best friend. People need help negotiating this phase. Or they'll go right back on that, I'm going to try to be who I used to be, I'm going to try to be who I used to be, that stabilization phase, and they'll go right back into crisis again. Well, in order to do that, you have to grieve at a whole different level. And that grieving requires a compassionate response, which has to be really encouraged. This is a 180-degree turn where we begin to be compassionate for how you've been suffering and how it's impacted your life and all the different levels it's impacted your life, including as a physical creature and as a sexual person. I'm going to jump down to socially interactively here. At this phase, people will often reintegrate some people who have left their lives earlier. There might be separation permanently for some of the people who have been in your lives earlier. And there may be a loss of supporters. I've never seen anybody go through the phases. I've never seen anybody who goes through the chronic illness experience who doesn't lose someone who's important to them. It doesn't have to be a spouse. It can be a friend or a relative. But it's very difficult for people to understand these experiences. So this is a time when there's an integration of new people, a letting go of some of the people who were in your life before, and a time of negotiation. And that includes negotiation about yourself as a sexual being as well. So we see here sexually is a renewed interest. There may be increased libido, and a whole variety of sexual strategies that we can begin to talk about clinically. Using scheduling, using reprioritizing, new flexible approaches, negotiating with your spouse, mutual support. Now, part of what's important here is to keep in mind that when you're in the crisis phase, you don't want to negotiate. It's not time to negotiate. And you can't really negotiate until you begin to have some appreciation of phase 2 in terms of the role and the dynamics changes. How have you changed? How has your role in your relationship changed? With your spouse changed? In phase 4, most people don't live in phase 4. They kind of visit there. They have moments of adaptation. They have moments where they really feel integrated. It's a time, if you've really begun to change your norms and your values, and you're adapting to this chronic illness experience, you're also adapting sexually as well. And psychologically, you're continuing to evolve. You've probably cherry-picked that pre-crisis self, and you've begun to integrate that into this new person that you're becoming, that you're learning to become. And there's a new personal best. And in that, you're evolving, and you're learning how to adapt in these new social situations. So, I want to take a few questions and hear some of your thoughts, but you continue to adapt, this continues to evolve, and you continue to accommodate. And the interesting thing is, whether you're ill or not, that's exactly what you have to do anyway, as a sexual being, and as a person. So, what's the most important thing to remember? Practice, practice, practice. You have to keep learning how to talk about it, thinking about it, not putting it outside your life. So any thoughts, any ideas about what we've talked about thus far? Not one? Not one thought? I'm going to start in the back. Yes, ma'am.
If you are at a point in a relationship where there's no communication, how do you bridge that gap to get to the point where you can talk freely again?
It's a very common issue. It's a very common issue. I'll make it gender specific. Here's what I've had people say to me. You know, he wants to have sex, but he won't talk about it. And I want to talk about it, but I don't want to do it. Does that sound familiar? Nodding. Okay. Well, I might start the conversation like this. I like to do this with topics like this, and I learned how to do this when I was a hospice worker. I was a hospice worker years ago. Anybody familiar with hospice? And before we could get families to talk about what was about to happen, which was dying, we would talk about talking about it. So we wouldn't necessarily jump in with, how do you feel about dying? Well, how do you feel about what's going to happen? Or can we start to talk about this? So you might start by saying, you know, I went to see this very odd woman from New York. And she said, yes, you like that. And she said, you know, she said that men want to do it, but they don't want to talk about it. Women want to talk about it, and they don't want to do it. And I'm trying to figure out how to talk about this. And she said, how do you sort of talk about it without talking about it? Because I really need to talk about this. Now, can I, like, call you on the phone from the extension? But you begin to find a context that's safe. And what are the parameters? You find a way to talk around it first. And let that person know that it's important to you. And that this is about your concern. It's not about them. Nothing they're doing wrong. Does that make sense? As a starting place, talk about talking about it. Unfortunately, I have to end. I'd be interested in your thoughts, and you can be in contact with us. I think there's contact information on your handout about AHMA. If you have any other thoughts you want to send to us, or questions or ideas, I'd love to have your feedback. Thank you.